Hey everybody, welcome back to the Diet Doctor Podcast. I'm your host, Dr. Brett Scher. Now today is part 2 in our 2-part series on intermittent fasting and time-restricted eating. Part 1 was an interview with Dr. Sachin Panda. So if you haven't heard that, I recommend you go back to that one where we really get into the science behind time-restricted eating. Now in this part 2, we're going to get more into the clinical aspects of it by speaking with doctors Kevin Gendreau and Steve Phinney and nurse practitioner Cynthia Turlow. And with them, we're going to really get into the nitty-gritty of the pros and cons of intermittent fasting and time-restricted eating, the clinical points to really help you with success, and what some of the concerns are. As you know, Dr. Steve Phinney is very vocal about, hold on, let's not get too fast on this fasting bandwagon until we have more science to back it up, and some of the concerns. So I really appreciate his viewpoint at the end. And then, of course, with Cynthia talking about women in particular, and the specific considerations we need to have for intermittent fasting with women. So this is a jam-packed episode with lots of good tips for you to take away and start potentially applying to improving your success with intermittent fasting and time-restricted eating. So let's get into the interview. Let's hear from Dr. Kevin Gendreau. Now, Dr. Gendreau has an amazing personal story, which he has transformed into a professional story. So he is a family medicine physician who is now board certified in obesity medicine and is has just made the transition to focus 100% on weight loss medicine within his medical group in Massachusetts. And he lost 125 pounds in 18 months. He had sleep apnea, type 2 diabetes, hypertension, fatty liver, and by switching to a low-carb diet with intermittent fasting and time-restricted eating, was able to reverse all those chronic medical conditions and lose 125 pounds. And as part of his journey, he wrote a book, Fasting While Furious. He's very active on Instagram and Twitter at Kevin Gendreau, Gendreau. I definitely recommend checking him out and following him. But let's hear what he has to say about the clinical side of working with patients with intermittent fasting and time-restricted eating. Well, Dr. Gendreau, it's great to have this opportunity to speak with you because we just heard about your amazing story and your personal transformation, and now how you've transformed your practice as well to full-time obesity medicine. And you have used intermittent fasting both for yourself and for your patients. So first I want to hear kind of what role do you think intermittent fasting played in your remarkable health transformation?
Thank you so much for having me on. I'm a huge fan of your show and your website. Dietdoctor.com is a resource that I share with every single patient that I see in the office. So it's like such an honor to be here and join, these other guests that you've had on the podcast. So thank you for that. Fasting is definitely something that's very personal for me. I did go through a weight loss journey of my own back in 2016. I lost 125 pounds in 18 months. And my very first intervention for the weight loss was switching to a low carbohydrate, clean eating diet. And so my starting weight was 306 pounds, and I slowly went from 306 down to about 230 pounds. Ultimately, I decided to read the book, The Obesity Code by Dr. Jason Fung, who's been a guest of your podcast and is very well known in the fasting community. And after reading his book, I was able to incorporate intermittent fasting, time-restricted eating into my lifestyle quite easily. Actually, I did an 18-6 fasting ratio most days and was able to go from about 230 pounds down to 180 pounds. And I continued to do my low-carb approach to weight loss at that time. So really, it was a combination of the intermittent fasting plus low-carb. And I use that tactic to really help my patients now lose weight in the obesity clinic. So I was practicing as a family physician for the past 4 years and recently transitioned to full-time weight loss medicine, where I work alongside bariatric surgeons, helping patients pre-op and post-op lose weight, and then also helping some patients avoid surgery altogether with weight loss.
Yeah, so I mean, it's so powerful when you can talk to a patient and say, this is what I did, look what I did. You know, the old saying, walk the walk, talk the talk, and all that. And you obviously did that. But not everybody is going to make that same transition that you did to go low carb first and then intermittent fasting, although it's clearly a very effective approach. So when you're working with patients, do you see a difference in, I guess, both success and compliance and sustainability for those who go low carb first and then intermittent fasting, or those who just try intermittent fasting no matter what their baseline diet is?
That's such a great question because as a weight loss doctor, you do have a lot of patients who come to you with preconceived notions and things that they want to try right away. Like they'll come to you with your first visit and they'll say, I would really like to leave here with a medication, or I would really like to start an intermittent fasting regimen. And so it does matter the order that you do things a little bit when it comes to success. It seems to be that if you start a low carb, clean eating approach first and you do dietary changes first, the intermittent fasting just seems to follow. And it's actually just kind of a natural progression for most people. I didn't even realize that it was, happening to myself while I was losing the weight. And I noticed that I was just eating in an 8-hour window on my own without having even read the obesity code, without even knowing much about intermittent fasting. And so I do like that order when I'm advising patients. I tend to tell them to clean up their diet a bit, try to minimize or eliminate even processed foods. And I encourage them to eat things like berries and vegetables and meats and nuts and full fat yogurt and eggs. And then down the line, sometimes not even in the first visit together, will incorporate intermittent fasting as another tool to push the weight loss further, particularly if they hit a plateau like I did myself.
Yeah, so it sounds like you advocate dietary changes, food changes first, and then timing and intermittent fasting second. But you brought up a wonderful point that when you make a change in the foods that you're eating frequently, the intermittent fasting, or at least the time restricted eating, just becomes naturally. And I think this is an interesting point to make, because sometimes when people hear the word fasting, it's got such a connotation to it, and people think hunger and sacrifice and uncomfortable and like, why would I want to do that? But the time restricted eating part, which is certainly part of intermittent fasting, can come natural and can just feel like you're not even thinking about it. So how do you sort of work around the concept of fasting versus time restricted eating? And when do you think it's appropriate to add in longer fasts that may be a little uncomfortable, a little more challenging, versus just sticking to the time restricted eating that can come naturally for so many people?
Great question. So I don't have a specific rule for my patients for how long I think that they should fast for. I have such a variety of patients that I see, from other physicians to nurses to super busy professionals like lawyers and stay-at-home moms. I mean, there's like everything in between. So there's people with all different types of schedules. And so what I say for intermittent fasting and time restricted eating in general is do what works for you. There's quite a bit of patients that I work with who will do a 12-hour fast, a 14-hour fast, which doesn't seem like much, but it has been shown to show some benefit with in terms of insulin sensitivity, improving insulin resistance. So I just think the best intervention is really just what works with your schedule and what works with your preferences. So if you're already on a low carb diet and losing weight, but you want to progress that a little bit further, just adding in a 12-hour fast as a scheduled thing, where every night you fast from say 7 p.m. to 7 a.m. the next morning. Or maybe you're a super busy professional who can only eat in a 4-hour bracket of time, like 4 p.m. to 8 p.m. is kind of your eating time every day. And you want to make sure that you get to have dinner with the family every night. So really, it's just schedule dependent, and what you can do, whatever you can to incorporate it into your schedule. Other people will do 1 or 2 24 or 36-hour fasts during their work week. Typically, I tell people, don't fast beyond 36 or 48 hours without talking to me first. I don't really get too much into the extended fasting. I know that Dr. Fung does that with the fasting method, but I typically tell people 12, 14, 16, 18-hour fast. Quite a few of my patients are on 1 meal a day fast, where they frequently fast for 23, 24 hours at a time. But when it gets to beyond the 36-hour mark, of extended fasting, 2 days, 3 days, typically I don't follow people in that way and advise them to do that.
Why not?
I guess my biggest concern is follow up. So, our patients have follow up appointments with us on a 4 to 6 week basis, and then they follow up with our dietitians on like a 1 to 2 month basis. And then we also have other staff that helps with certain things like binge eating disorders, emotional eating, history of eating disorders in general. So we have social workers and therapists that help with that. They're licensed clinical social workers. So they'll see patients on a 1 to 3 month basis. And so I find that if you're going to go past the 36, 48 hour mark, maybe 72 hours or beyond, you need a closer follow up than once per month.
Yeah. And I think that is important to differentiate the longer fast from the shorter fast and time restricted eating. There really does seem to be like a line in the sand, sort of where the risks and the complications and the challenges start to rise. And it's sort of unclear how much the benefits also rise. So I think that's a great point, that the sweet spot is more in the time restricted eating and the shorter fast. So you brought up the eating disorders, and that's another sort of controversial topic when it comes to fasting and time restricted eating. So do you have concerns about using intermittent fasting or time restricted eating in patients who have a history of these eating disorders?
Certainly. So during our first visit together, I always make sure to bring up history of eating disorders. And I typically will describe some common eating disorders, like binge eating disorder, for example, since it's the most common among both men and women in the US. And I'll describe that to my patients and see if any of it resonates with them, because intermittent fasting is okay for the vast majority of patients. But if you have a history of something like severe emotional eating or anorexia or bulimia or binge eating disorder, it may not be right for you. Particularly someone who has a history of anorexia, maybe being underweight, being malnourished, it might not be the best option for them, to lose an extra 5 pounds or something like that. Like if they're already in the normal weight bracket for their height, it's probably not the best intervention. And then someone who tends to binge may unfortunately get so hungry at the 18, 20, 24 hour mark that they make bad decisions. So it could still work. And I personally have a history of binge eating and still make intermittent fasting work for me. But it's just something where it's like that extra layer of risk. And it's something that we have to cover and discuss and really explore patients' feelings about that.
Yeah, I love that you make that a priority to describe that ahead of time, and to describe what the, binge eating disorders or emotional eating disorders can look like, because they may not feel like they're labeled as a binge eater or an emotional eater, but when you describe it, it may start to sort of ring true, and to sort of prepare them for that. And that's something that you don't necessarily get if you just see somebody on the internet talking about intermittent fasting and say, "Oh, I should try this." And in my experience is that the people who kind of fail or don't do well are exactly those people who sort of make up for it by binging after they're fasting, and they wouldn't know that they're at risk for that unless they had someone counsel them or at least bring it up. So I think it's so important that you bring that topic up, and that is great. But once you establish that they have that, does it mean fasting's off the table, or does it mean you can still do it just with certain precautions? And what might those precautions or those other interventions be?
So I think if you have a history of binge eating tendencies, emotional eating issues, maybe even possibly a history of bulimia, like a remote history many years prior, it's still possible to do something like intermittent or time restricted eating on a 16 to 8 or an 18 to 6 schedule. I think it's really more extended fast, 24-hour fast and beyond that people should watch out for, that we should watch out for with a history of eating disorders. I think I've had several patients who actually, meet the criteria for binge eating disorder, and they are still able to follow an 18 to 6 schedule with no problem. And when they do tend to cheat and make a mistake, they do, forgive themselves. And I teach my patients a lot how to forgive yourself, how to love yourself. And so I
Right.
think like the rebound from that mistake that you make matters just as much as the mistake itself. So people tend to get off track for an entire weekend or an entire week or even an entire month after they slip up at a wedding or an event like a party. So I try to teach my patients to take it like one day at a time and don't, say that the whole weekend is ruined or the whole month is ruined because of one little slip up. It's just part of the, part of the weight loss process. We're not
Yeah.
perfect.
Such an important point. The whole emotional side of things and the internalizing of the, I did bad, I am bad, that sort of internalizing that message, which I'm guessing you didn't learn that in medical school, did you?
No, we barely had nutrition classes. It was like 4 hours out of 4 years.
Yeah. So when you think back to your own journey and your own challenges here as a physician to, get into the sort of health problems that you got into and get yourself out of it with fasting as part of that. I mean, fasting is still not really, I guess you could say not really well accepted in medical practice as a whole. But what about within obesity medicine? Like, is it starting to become more accepted? Are you seeing it among colleagues that it's being talked about more, or is it still sort of thought of as fringe and dangerous and maybe we shouldn't do it?
Yeah, so in our clinic where we work alongside the bariatric surgeons, we have three MDs who are all obesity medicine certified by the American Board of Obesity Medicine, ABOM, and we have two nurse practitioners working with us. And actually, all five of us, all five providers, do follow low carb recommendations for our patients, and we also use intermittent fasting to some degree. None of us really work with patients where we're encouraging them to fast beyond like 36 to 48 hours, but almost all of us do time restricted eating. And we've all noticed that it's just a natural progression. When you start low carb and your body starts to become fat adapted, you're just less hungry. And so patients will bring it up on their own anyway. And so a lot of us, we're all on board. And I think obesity certified physicians are starting to become on board as a unit, but I think it's going to take time for like the general medical establishment to be on board, even with just low carb, never mind the intermittent fasting in addition to that. I still have cardiologists and endocrinologists giving me bad feedback about starting patients on low carb diets and telling me that, Mediterranean would be a better way to help patients lose weight. And so we've kind of had to like finagle our wording a little bit and say, oh, it's low carb Mediterranean that we're starting patients on, and avoid the K word, which, like keto is practically a swear to some specialists, unfortunately.
Sure.
So
Sure.
it takes time to change minds, and the American Diabetes Association recently coming out with that low carb diet as an option for helping improve, insulin sensitivity and diabetes control
Mhm.
helps a lot. We need more bodies of medicine to support low carb plus intermittent
Yeah.
fasting.
Yeah, so it'll be interesting to see if some of these governing bodies come out and start promoting time restricted eating or intermittent fasting or timing of your meals, however they want to word it to take the sting out of it. Right? Again, intermittent fasting may have too much of a sting right now for certain governing bodies and certain guidelines, but you could word it as just timing of your meals or spacing out the timing a little bit or time restricted eating. Like all of those should be perfectly acceptable, although maybe they're still not. But do you have concerns about some potential side effects or risks for people, even with time restricted eating, whether it's an 18-6 or an OMAD, lean body mass concerns, or malnutrition concerns or anything like that?
I think if someone has a history of malnutrition or issues with electrolyte abnormalities, for example, or like recent unexpected weight loss, there are reasons to not start time restricted eating, but I don't have much in the way of concerns in general. I think most people in the general population, men, women, it's very safe to do something like time restricted eating 16-8 or 18-6. And the vast majority of patients, even people on medications, can do it. I would say it really only is if you're going past the 24-hour mark that it matters if you're taking medications that require food intake, like iron or aspirin or metformin or insulin. So those patients need a little bit of, extra care and extra concern for things like that. And there's also other comorbidities like type 1 diabetes that may need to be watched a little bit closer when it comes to fasting. But I think that's really more prolonged fasting. I think shorter intervals and time restricted eating is safe for the vast majority of people. I would say pregnancy, children under 18, breastfeeding. Those are kind of the only things that are hard stops for me in the clinic. We do see adolescents ages 13 to 17. And I don't do any kind of time restricted eating with them. I focus more on clean eating and getting rid of processed foods, which seems to be the main problem with teenagers. So
Yeah, I'm sure. Yeah, I think those are all great points for people to sort of hear. And if they are in one of those groups, don't start this on your own, but consult with an expert like yourself to see if there is a place for it. Because again, people sometimes people want the quick fix, right? So the quick fix used to be and still is, unfortunately, medications and pills. But I think some people maybe see intermittent fasting as a quick fix also, but it's not always the case. It has to sort of fit into a whole program. Do you see it so similarly?
yes, that's true. So I think people look at intermittent fasting, specifically longer fasts, as a quick fix. So, like,
Yeah.
I want to get rid of these 10 extra pounds. So I'm going to fast for 5 days or 7 days or 10 days. But I like the slower, longer approach where we work with people on fixing their nutritional habits and having them eat cleaner foods and then let the intermittent fasting follow on more of a schedule where it's like 1 day a week I'm fasting for 24 hours, or every day I eat between 2 p.m. and 7 p.m. So I like,
Yeah.
more of a schedule and more of a predictability. And that way you're not binging on the weekends on tons of processed carbs and then restricting yourself for 3 days, which is almost like a bulimia cycle where it's kind of just it's not quite disordered eating, but it's like almost there where you're using the fasting to negate all of that food that was terrible that you just ate the few days prior. So it's hard. It's a fine line, but I usually tell people to try to incorporate it at first, 12 hours, 14 hours, and you can progress from there and maybe get to that 18-hour mark. Because we know that, autophagy really happens between 12 16 plus hours. So if you can get to the 18-hour mark for fasting, I usually say that that's pretty good, and people can maintain that over time in their schedule. Most people can do, a 6-hour eating window every day.
Yeah, so that's interesting. I mean, this whole topic of autophagy or autophagy, like when does it kick in and how do we know? And the science behind that, I think is very difficult to interpret and apply to humans to know where that threshold is. And people want to know like the effective minimum dose, right? If you knew that 16 hours was the minimum dose that was where you hit the sweet spot, then most people wouldn't fast for 17 or 18 or 20 hours, right? They want the minimum, the
Right.
minimum effort for the maximum benefit. So I guess you're saying you believe that is right at about the 16-hour mark.
Yeah, so I tell people to start with 12 hours, 14 hours, but if we can get them to the 16-hour mark, 18-hour mark, I feel a little bit better about it. And I've seen more success with that in clinic. That's just anecdotally. That's not like I don't have numbers to prove it. I'm not like a research scientist with all this data. I just tend to focus on like a 16 to 18-hour fasting window. And if people can only do 12 or 14 and that works for them and they're eating low carb and losing weight, then that's totally fine too. I tend to not like push a specific number, but really, I think the greatest success that I've seen has been 16 to 18 hours for fasting.
And I sort of asked you this before, but I want to ask it a little more pointedly now. Do you have to eat low carb to succeed with intermittent fasting?
I think it's the most successful. I mean, it's the best combination there is, but I think it is possible to eat carbohydrates and fast and lose weight. I just think it may take longer. If you look at certain cultures and groups of people, they're able to eat things like rice and beans and incorporate intermittent fasting and still lose weight. So I think it is possible, particularly if the foods that you're eating that are carbohydrate containing are complex carbs or certain grains that are naturally occurring and not processed. So I think it's possible. I just think the best combination is a low carb diet. Usually we focus on 40 grams, 50 grams or less per day of carbohydrates plus the time restricted eating.
So one last question for you, and this is a question that so many people ask when they're getting started with intermittent fasting or time restricted eating. What can I have? What is considered okay for a fast, and what's going to kick me out of the fast? Do you have advice for people on that?
Yeah, that really is the most common question. I think every single patient who who comes to see me and we talk about time restricted eating, they want to know what they can have while fasting. And so in general, I tell them the cleanest fast is just a water fast with nothing in the water, no additives, no fake sweeteners. But many people have so much success with tea, with coffee, as long as there's no sweeteners, with things like bone broth, so chicken broth or beef broth. Sometimes people will have a bit of pickle juice. Sometimes people will put a little salt in their water. And so overall, as long as you're keeping it under 35 calories during your fasting window, you should be good. And I also think it's important. There are many products out there. Crystal Light is just one example where they're technically zero carb, zero sugar, zero calorie, but they may elicit some kind of response when it comes to your body's hormones, like insulin, for example. So those things are really also important to stay away from during your fasting period.
Yeah, it's interesting. Even if it has no calories, one thing it can do is sort of make it more challenging because it can trigger insulin and glucose swings or hunger or cravings, and it can make it harder just to comply with the fasting, let alone what it does to your hormonal changes, which may counteract what you're trying to do with the fasting. So that's a good point because a lot of people think as long as it's 0 calories, it's clean. But that's an excellent point that you bring up that we have to be maybe a little more concerned about even some of those. So, well, thank you. I really appreciate you taking the time and joining us today.
Thank you so much for having me.
Next, we're going to hear from Cynthia Thurlow. Now, Cynthia is a nurse practitioner and the CEO and founder of Everyday Wellness Project. She's an international speaker, including a couple popular TED Talks, and she focuses on a lot that has to do with wellness, but also specifically intermittent fasting, but specifically intermittent fasting for women. Now, a lot of the times we hear of intermittent fasting as if it's one thing, one protocol, one way to do it, but that's definitely not the case. And as we're going to hear from Cynthia, not only do we have to worry about or consider lots of different things about intermittent fasting, but we also have to consider its role according to your gender. And not just man or woman, but when you're a woman, what age are you? Where are you in sort of your menstrual cycle? And all of these things will play into how intermittent fasting may affect your body and how you may be able to comply with intermittent fasting. So, Cynthia, you speak a lot about the differences of fasting for women. So give us an overview of what you see as the main differences and some of the similarities that you have to consider when speaking to a woman to try and get them interested in fasting and involved in fasting for health benefits.
I think it's a great question. And I always like to start off by saying, women are not many men. So we have to approach fasting a little bit differently. Most of that is due to our menstrual cycle and the impact of fasting on where we are in our cycle, whether we're in the follicular phase or the luteal phase, how close we are to menstruation. That is absolutely paramount because our bodies are designed to be able to procreate and carry a healthy pregnancy. And for that reason, we are much more sensitive to hormetic stressors, whether it's like finding that Goldilocks effect of not too much, not too little beneficial stress. And so fasting is something that I look at as a beneficial stress if in the right amount at the right time. And so when I'm counseling women, I always say if you're under the age of 35, I kind of have a different methodology than I do with women north of 35, but yet not yet menopausal. And then menopause is when I feel like women and men are most aligned in terms of their hormones are a bit less fluctuating from day to day. And therefore, I find oftentimes menopausal women and men have a lot more similarities than they do dissimilarities. And so when I'm, starting out conversations, I want to know where is a woman still menstruating, where she is in her cycle, what's her sleep quality like? Because my kind of resounding philosophy is if you're not sleeping through the night, irrespective of gender, it's not the time to be adding in another hormetic stressor. I think quite a bit about nutrition and I think about stress management. And unfortunately, I think so many of us have been conditioned to believe on many levels that when we're talking about oftentimes body composition, wanting to lose weight, desiring to lose weight, we have to work out really, really hard. And so as it pertains to women, I really think about all of those key concepts when we talk about fasting to make sure all of those things are dialed in properly so that they don't get a net negative impact on their menstrual cycle or their fertility.
Yes, you mentioned sleep, which is obviously a very important factor in health. But when women are perimenopausal, that's a time in their life where sleep can really suffer. Waking up with hot flashes and just really the hormonal changes can really keep women from sleeping well. So do you find that perimenopausal women really suffer or have a harder time with intermittent fasting because of that? Is that a particularly difficult age group?
I think it is a particularly difficult age group because things that used to work are no longer working. Like what served you in your 20s and 30s, suddenly you're completely spun out because you recognize that, the degree of exercise intensity, the amount of stress you're mitigating really doesn't serve you any longer. And for anyone who's not familiar with this perimenopausal period, we know that it's a time when we're not ovulating every month. We're getting waxing and waning progesterone levels from our ovaries, puts a little bit of stress, additional stress on our adrenal glands. And so you're aptly, very appropriately mentioning the sleep piece. And so I will really start there. And it can be as simple as women having to really execute really good sleep hygiene. I think back to when I had infants and toddlers, and there was a whole sleep ritual that we had to create. And I said, we very much have to think the same way. We have to be that proactive so that we are preparing our bodies for bed. And it could be as benign as getting off electronics or wearing blue blockers that mitigate the blunting of melatonin secretion in our brains. And, really just being very mindful about what we're doing preceding bedtime. And so I find for most people, most women, when they start making the appropriate changes, even before we think about supplementation or, medication or anything like that, many simple changes can really add up. And it could be that, adjusting their macros during the day, the protein and fats and carbohydrates can make a huge difference. I find many people, when they start fasting and they start adjusting their macros, their hot flashes go away or they become much less problematic. They have a whole lot more energy. And so the sleep piece is critical. I always say it's foundational to our health. So irrespective what gender you kind of fall into,
Yeah.
I think that if you're not sleeping properly, you want to be really careful about, what your fasting schedule or regimen is like.
And you mentioned a couple of different age groups. So under
Mhm.
35 and then over 35, but still menstruating, and then postmenopausal. Do you have a different frame of mind in terms of duration of fasting? Because I fall into this pattern as much as anybody. You talk about fasting as if it's one thing, but it clearly isn't, right? You
Mhm.
can do time restricted eating, whether it's 12,
Mhm.
14, 18, 20 hours. They're all time restricted eating. Or you could
Mhm.
talk about 2, 3, 4, 5 day fasts even. So do you have
Mhm.
different time frames that in this age group you want to focus on this time frame, in another age group you
Mhm.
focus on a different time frame specifically for women?
Yeah, I mean, I think for anyone who's still in their peak fertility years, and I like to think of that as 35 and under, if you're particularly lean, I don't think there's a lot of benefit from doing very long fasts. In fact, you start to really look at the net impact of prolonged fasting in someone who's very lean, potentially very fit, and very young. And there's that cost benefit where I just don't think it's there. So in younger females, I usually will say, 12 hours of digestive rest is great. 12 to 13 hours the week preceding your menstrual cycle is great. That's fantastic. You're still getting benefits. I don't like prolonged fasts. Like, I don't want, unless someone is clinically obese, working with someone who's very talented, is very familiar with intermittent fasting, and you've got a lot of connection with someone that's knowledgeable about fasting. For the average 35 and under young woman who's still in her peak fertility years, I would say, 14 to 15 hours are probably fine. It's certainly not every day, every other day, twice a week. I'm not as stringent. Now, again, if someone's morbidly obese, working with a clinician that's very knowledgeable, you could certainly try some other strategies if you've got a lot of weight to lose. But the lean, thin, type A little bit OCD young women that I do see on social media, I get a little bit concerned when they want to fast every single day, because I look at the menstrual cycle really as a barometer or another vital sign. If your menstrual cycle, if maybe one or two cycles get a little bit off, maybe they're a little shorter, a little longer, there's no chance of pregnancy, or you've taken a pregnancy test, that's one thing. But when someone becomes amenorrheic, if they lose their period entirely, it's a sign that it's too much stress for the body. So that's that kind of group. I would say perimenopause, 35 to 50, if we're going to just make a blanket statement. This is when women really can struggle quite a bit. And so
Yeah.
I take it on a case by case basis. I do like people to aim for that, again, that 12 hours of digestive rest, and slowly start moving that fasting window out to see where they're functioning. What I do see in terms of, people get hooked on, they're less hungry, in this age group. This is when, as they get closer to 40, whether it's the role of estrogen on, digestive health. But I do see women who aren't as hungry. And so they'll justify one meal a day. And I keep telling them there is no way possible you can get enough macros in one meal a day in perpetuity. If it's around a holiday, if it's around a celebration, you overate the day before, OMAD is fine. But there's just no way you're going to be able to get, enough macros in to sustain your body. And so with women like that, it really is on a case by case basis, focusing on the sleep, the stress management, not over exercising. And I just find we're a very carbohydrate focused culture. And when you're looking at statistics that like 88% of the population is metabolically unhealthy, I remind people that we really need to focus on the key satiety macros, like focus on animal-based protein, adding in some healthy fats if they're not already part of the animal-based protein that you're consuming. And then carbohydrates should be like the last thought. I'm not anti-carb. I do think that there's value in women being very targeted about carb cycling or, adjusting their carbohydrate intake based on where they are in the menstrual cycle and how active they are. But so that's one bucket. Again, kind of paying attention to what's going on with the menstrual cycle. And then I always say menopause for many women that are fasting, they just find it so much easier because there aren't all these hormonal irregularities that they have to kind of mitigate and worry about. So that's where I think men, for the most part, and menopausal women really can excel because they aren't worried about the childbearing net impact. For many people, it's a time in their lives where they have maybe less responsibilities. Their children may be out of the house. They may just have to focus on themselves and maybe a spouse or significant other. So it might be a time that women are in a position to be able to invest more into their health.
Yeah, I think that's a good point too. What else is going on in your life and how crazy is the rest of your life that it's not always a good time to be fasting or to be changing your routine on a regular basis. So that's a good point. But you also brought up OMAD and getting enough macros. Whenever I hear that, I think not getting enough protein, especially for women as they age, because traditionally, I guess stereotypically, women undereat protein anyway, especially if you want to maintain or build lean body mass. So when you talk about fasting, a big concern can be, are you getting enough protein? So is that something you see in women, that they're just under eating protein for the sake of fasting? And how do you weigh, the risks and benefits there?
Yeah, it's a great question. I talk a lot about sarcopenia, the muscle wasting with age that is of greatest concern. So I always encourage people to be aiming for more protein intake. And it could be that they go from 3 ounces of fish to 6 ounces of fish. It could be that they are having 3 meals during their feeding window. It might be that they may add in a high quality protein powder into that mix. But, if you look at, muscle protein synthesis research, what it's really talking about is you need to have this leverage of enough sufficient protein intake and then the strength training piece to maintain muscle mass as you're getting older. And I remind people, sarcopenia is going to happen unless you do a lot to change it. And I think the disadvantage that women in perimenopause it's that slippery slope. We build peak bone and muscle mass in our 20s and 30s. And so a lot of people aren't thinking about muscle mass and bone mass until they're in their 40s and 50s. And maybe they notice it's a whole lot harder to build muscle. It's a whole lot harder to maintain their bone strength. And especially if they've got genetic susceptibilities to osteopenia and osteoporosis. So from my perspective, it's a huge focus of my work. I remind women that protein is satiating and it's critically important. And I think that the challenge that I have is when we're talking to a woman who wants to change, for example, her body composition. Maybe she's put on some weight in perimenopause or menopause, and they're very carbohydrate focused or they're plant-based. It can be very challenging to get those protein macros where they need to be. And I kind of align myself with Dr. Gabrielle Lyon, who talks a lot about 1 gram per pound of ideal body weight. So if someone's aiming to be 140 pounds, that's quite a bit of protein. And maybe they're only getting 60 at that point. I always say, you're going to stuff yourself if you try to hit 140. So aiming for 10 to 15 more grams each day over a period of time, and then also giving themselves some grace. 100 grams is what everyone should be really aiming for at a minimum. But if people can get to 110, 120, great. Don't beat yourself up. But I think for women in particular, if they want to ward off sarcopenia, they want to have muscle, calorie building muscle. I always think of muscles as a glucose reservoir. And so we know we become more insulin resistant as we get older, as we start creeping towards menopause. And I just tell people, you can be doing all the right things. And if you are losing muscle mass, it is going to be a whole lot harder to maintain a healthy weight and remain as metabolically flexible as you would like to be.
Yeah. So if you have a patient who is not very excited about exercising, they just struggle to do it, they're not consistent with it, and they sort of undereat protein by a little bit, not maybe 50, 60
Mhm.
grams, but say like 70 grams or so.
Mhm.
If you have a patient like that, would you just take fasting off the table, or do you still see a role for intermittent fasting or time restricted eating even in that scenario?
I think intermittent fasting or time restricted eating is good for just about everyone, even if it's 12 hours of digestive rest. If someone says to me, I'm really struggling to get my macros in, I'm hungry, I'm going to bed hungry, I'm waking up hungry, I would say, okay, let's restructure things. We can always back down. And that's the key thing about fasting that I think is so critically important for people to understand. It's not about rigidity, it's about flexibility. So you may flex up and down every day. It might be that someone does intermittent fasting every other day. If someone really doesn't enjoy exercising, doesn't enjoy longer periods of not eating, I just say, then let's eat less often. If we're going to make it as amenable and friendly as possible, like let's eat less often. Maybe you do a 10-hour eating window. You eat 3 times, you get all your macros in, you're not waking up hungry. And, fasting can work at different points in our lives. It is totally okay if someone takes a break. I certainly have after being hospitalized. And I think it's important for people to understand that it's not an all or nothing phenomenon. Like you may fast for 6 months and then you may have an illness or you might move, or it might just be more convenient to do like a wider feeding window. And that's okay. But it's really about focusing on eating less often, eating for satiety, pushing the protein envelope so that you are contributing to, providing your body with the amino acids it needs to maintain lean, healthy muscle. And, really thinking strategically. Like I remind people, I think it's almost Mother Nature's way of reminding us that we need less food anyway. Like it's surprising when people restructure the way that they're putting their meals together, how much better they feel. They have more mental clarity, more energy, they're sleeping better. And I'm like, it's something that's so simple, and yet it's so intrinsic to how we are as human beings. And so, for many, many levels, I think that, when people just kind of become more attuned to what makes their body feel good, it will naturally follow along. But I agree with you. It's all about finding what works best for the patient and being really flexible and encouraging them to be flexible and to give themselves some grace.
Yeah, I think that's such an important message because, so many people get lost on social media and, the concepts. If you're not doing OMAD every day, or if you're not doing a 5-day fast, you're not really
Mhm.
fasting. You're not really getting the benefits. So you got to do it that way in order for it to work. But your message is so important that no, sometimes even just 12 hours of not eating, or just
Mhm.
cutting out snacks, or sometimes just the little differences can make a big impact. And I
Mhm.
also love your message that is not one way all the time. You can cycle in
Mhm.
and out. You can change the duration. And as you alluded to before, someone's menstrual periods may play a role in that as well. So, do you have women do longer fasts, like right after their period, and then shorter fasts, or let me rephrase that: a longer time restricted eating right after their period, and then shorter leading up to their period? Do you usually have them on a protocol that sort of expands and contracts based on that?
Yeah, I mean, I definitely am of the belief system that the 5 to 7 days preceding their cycle, if they have a 28 or a 30-day cycle, they should not be doing fasting. We also know it's when women are most insulin resistant. So I may have them tweak their macros. And then once they start bleeding, when they're most estrogen, I don't want to use the term dominant because that gets mistaken, but we know that estrogen dominates as the predominant sex hormone in the first half of the menstrual cycle. That's when they have a lot more energy. That's when they can get away with longer fasts. And then as they get closer to ovulation, they might be doing shorter fasts. And so, yes, like teaching those kinds of techniques, I think is really important. Also, women just feel so much better because they enjoy the fact that they can flex or they can flux that fasting window throughout the month, and they don't feel so compelled to have to be rigid. Like I had actually a clinician texted me the other day and said, I feel awful. I can barely get to 14 hours fast. I said, where are you in your cycle? And the next text was, oh, my period should start tomorrow. And so even clinicians will do the same thing. They're like pushing, pushing, pushing. And then all of a sudden they're like, why am I having so much trouble trying to squeak through the last couple hours? And I'm like, listen, break your fast. Like I certainly do it. I have days when it's like that. And I'm like, listen, I don't want to. I choose not to. I don't believe in forcing anything. There's very little that needs to be forced as it pertains to, creating, the circumstances, the schedules that work best for you. And, along those same lines, when I think about people wanting to do long fasts, I always say, a lot of it's a mindset piece. So you have to be ready to say, okay, I'm not going to consume X during this, 24, 48 hours period of time, but also be methodical and strategic. Don't do it around celebrations when you're going to have people around you eating and celebrating and you're sitting there feeling deprived. It's going to make it a whole lot harder to be compliant. Do it when you're busy. Do it when, you have, maybe you've got a work project or you're traveling, but pre-COVID, I used to always say that's when I would do a longer fast. If I knew I was going to get on an airplane, change time zones, and I'm like, I don't like the airplane food. I don't like the airport
Mhm.
food. It's easy to do this. I'm just going to stay hydrated. So really figuring out what works and resonates best for you, I think is a really healthy strategy for people to embody.
Yeah. Now, switching gears just a little bit here, what about the statement that when you eat is more important than what you eat? Is that true? Because obviously, what you eat is still important. When you eat is important.
Mhm.
Is it truly more important when you eat than what you eat? And would you have somebody work on their eating window first before changing the actual foods they eat? Or how do you see those two sort of competing variables?
Yeah, great question. Well, I would say my kind of prevailing thought process about that is, if we follow chronobiology, we would eat earlier in the day and not be eating in the evening, not be eating 3 to 4 hours prior to bedtime. But when I'm working with people and they're new to fasting, we try to clean up the snacking first. So I always say we're taking baby steps so that we can put you in a position where you can be successful. So get rid of the snacking and then adjusting macros because we want the satiety to come before we start doing these fasting windows, because I find if I can get people, and it seems like a lot, I mean, as you know, as a clinician, there's a lot of people that are leptin resistant. They're really struggling. They the satiety cues they just don't have. So really working on making them feel full, a little more protein, being mindful of your healthy fats because they tend to be more nutrient dense. As we start restructuring meals, then they feel empowered. Then they're like, okay, I
Yeah.
wasn't hungry from dinner to breakfast. So, okay, I got this. And maybe I can go to 13 hours fast and I can go to 14. So, my traditional methodology is really meeting people where they are first. And I always tell patients, tell me the honest truth because I can help you better if I know where you're struggling the most. So when it comes back to, when you eat is more important than what you eat, obviously both are important, but I try to get people to close their feeding windows way earlier than 7, 8, 9 o'clock at night when they're going to sit in bed with a full stomach and they're not going to sleep well. And reminding people we've got melatonin receptors in our gut. I mean, we have all this hormonal regulation and communication within our body, and we really want it to be optimized. I kind of think about how the pandemic has allowed a lot of people potentially to adjust feeding and fasting windows because they've been home or they've been home more than they might normally be. And maybe they're listening more to their bodies about, hey, maybe I actually want to eat dinner a little earlier and I actually sleep better when I do that. So I encourage people to, really do a little bit of experimentation to find what works best for them. I have some patients who will close down their feeding windows way earlier than they did pre-pandemic because in many ways they've come to realize that they feel better when they're not going to bed with a full stomach.
Well, then I guess the last thing we should talk about is I hear you have some exciting news about a book coming out soon.
Yes, I'm really, really excited. That should be out in March of 2022. It's a book on intermittent fasting in women, really walking women through my personal strategies for not only cycling, but perimenopause and menopause, very focused on hormones, supporting hormones, and, the unique characteristics that, you know, really force us as women to approach fasting a little bit differently than men do. So I'm really excited for the opportunity.
Oh, well, I'm excited to see that. I think that's going to help a lot of women because really, we do get lost in social media and think of everything as one big lump. But we are individuals, and women are not little men. They need to be. They need to consider things differently. Exactly like you said. I think you phrased that very well. So I think that'll help a lot of people see things from a different perspective. So thank you for putting that message out there, and thank you for taking the time.
Absolutely. Thank you. It's been my pleasure.
Next, let's hear from Dr. Steve Phinney. Now, Dr. Finney is the Chief Innovation Officer at Virta Health, but his background, he has a medical degree from Stanford University and has a doctorate in nutritional biochemistry from MIT and completed postdoctoral research at Harvard University. Now, throughout his 40-year career, he's worked as a clinician and as a researcher with over 87 peer-reviewed papers. He's published data for more than 20 clinical protocols involving diet, exercise, oxidative stress, inflammation. He's a professor emeritus at University of California at Davis, and he's had clinical faculty appointments at MIT, University of Vermont, University of Minnesota, UC Davis, and he's been involved in industry. I mean, he's done it all when it comes to research on nutrition and health. And now, of course, you probably know a lot of the work that they've done out of Virta Health, where he is a co-founder and has been instrumental in their work. So when it comes to fasting, though, he's also been pretty vocal about needing to follow the